Again.
Why are you so low?
Um, Healthcare improvements, innovation work on psychology of change methods for quality improvement. She is a leadership faculty for Atlantic Fellows for Healthcare Equity. And Kate also has experience in coaching healthcare system teams on workforce well-being and quality improvement. So, if you will, thank you, Kate, for being here with us today. And we do look forward to your presentation. So, if everyone will welcome Kate.
Thank you so much. Thank you for having me. I'm so excited to be here to speak with all of you about the important work that you're leading. We're talking a lot about building momentum in burned out times, and I wanted to start with all of us on the call here today in terms of how you're feeling, how you're doing. I'm wondering if you might just pop into the chat your sort of where you're at in terms of your stress. How would you rate yourself on the scale that you see here of 1 to 10? Are you feeling high levels, moderate, mild, no stress? As we think about burned out times externally, I also want to invite us to consider it internally. All right, so I'm seeing some 4s, 3s, 1s. I'm guessing hopefully there's some effect of summer months, some time off, some not sure. Great. It's nice to see that we might also be a self-selecting group. There may be those that haven't been able to join us today because they're burned out. And I see a few that are in a moderate space. So just to honor everybody, no matter where we're at, I'd like just to invite you to take a few cleansing breaths. Find yourself in your own center and notice where your body is at right now. Sounds like most of us are doing okay, but we'll just take a few breaths to regulate and center ourselves. So in and out, in and out, shedding any stress from earlier today or a previous meeting, turning off our devices, our email, just finding our breath, letting go of things we may be bringing and turning our attention to our time together. And one more breath, in and out. And just a reminder that taking a few cleansing breaths at the start of a team meeting, at the start of a webinar, at the start of a huddle is an opportunity to help invite people to do the same, to cope with what it is that they're carrying, to find themselves centered in their own body, to feel a feeling of self-compassion or connection. Sometimes also we're carrying things that may bring some tension or some temper into the space. So this is an opportunity also just to help people slow down, calm down, regulate. And you don't have to do it for long, as we did just a few minutes of gathering ourselves together and noticing ourselves. And the reason why we do this is because it allows us to regulate our brains. So the neuroscience behind this suggests that we are, thinking a lot about the fight, flight, freeze response in our primitive brain or in our brain stem, and that's where we feel out of control or anxious or stressed, and it's there to do its job, which is to release adrenaline and cortisol that rev up our body on high alert, and that's great when we need it. But too much of these hormones are physically harmful, and that creates anxiety and stress. And that relaxation techniques can include breathing, can include nature, yoga, meditation. So one way we can help people regulate their emotions that underpin sort of feeling burned out can be to breathe and to create safe space to do that together. The second, though, is to then relate, and that's in the amygdala or the limbic part of the brain, where we have feelings, where we feel emotions of fear or of hope, where we can release the hormone dopamine that generates feelings of pleasure by feeling connected to others and thinking about how we do that with one another. And then that frees us up, because if your primitive brain or your limbic brain, if your brainstem or your amygdala are gummed up with fear or fight, flight, or other feelings of burnout, it actually prevents us from being where we need people to be in improvement work, which is in their prefrontal cortex, in the cortical brain. And that's where we are our most self-assured, our most creative, our most resourceful, adaptive, and of course we need that when we're doing the strategic work of improvement. So in order to help people, be in that space, we want to help regulate, we want to help relate on our teams and with the people with whom we're working, as we individually and collectively may be experiencing or responding to burnout. Now, burnout itself is predominantly a systems issue. So these individual factors of breathing and meditation and coping and resilience, that is important, but it really only contributes to about 20%. What we found is, in fact, see somebody, okay. Really need to look at the system factors around burnout, some of which are in our own locus of control, which we're going to talk about in a little bit, and some of which are not. And so just being mindful that, within not only just our patients, but also the clinician-patient relationship and the workforce relationship with one another and its own well-being, we're thinking a lot about not just, again, those personal factors or those skills and abilities like breathing and meditation and feeling connected, but also larger contributions of rules and regulations, organizational factors, the learning practice environment, the responsibilities on our plate, the burden of the workload, and so on. So, we're doing this work at a time when we're facing great change in the U.S. healthcare landscape and have been at a rapid pace for multiple years, at least since COVID, if not prior. We were already seeing high levels of burnout amongst the workforce prior to COVID. And as you can imagine, not just COVID, but then what has happened with regard to staffing, with regard to workloads, and now new technology challenges with AI and the EHR, administrative burden, and so on. These are things that we're responding to. So it's in that backdrop, of the systems factors and the personal resilience practices, that we're going to think a little bit about mindsets for addressing barriers to improvement amid these times that we're in, and discuss different strategies for engaging folks and maintaining motivation in the work that you're leading, so that we're inviting people to adapt and adopt the change packages that you're taking forward, and think together about how to apply them in our improvement work. I hope that the session will allow us to feel energized and the opposite of burnout, and of course remind you of the support you have across this network. So I'm happy for folks to either unmute themselves or just to put in the chat that in the face of burnout, what barriers are you facing in your improvement work? How could you locate today's session in the context within which you're leading the perinatal collaborative work? Any thoughts? Any specific challenges you're facing? We can certainly also workshop some of these challenges and address some of them with one another today.
Hi, Beverly. I'm sorry, Kate. Beverly had her hand raised.
Oh, great. Right. Thanks for helping me. I couldn't see it. Go ahead, Beverly.
Good afternoon. I would say one of the barriers that we face from time to time with our improvement work is having the right stakeholders at the table for the discussion. And because sometimes we're working on the same problem, but not aware that someone else is maybe working on the same one or have a different angle that they're focusing on. And when we can come together and talk about it, sometimes it just makes the work lighter because you realize someone's already covering that, or there may be some other assistance that you need and people will volunteer to help.
Fantastic. Yeah, really appreciate that. We're going to turn to that too as we think a little bit about how to map our actors and allies and look for shared interests and ways in which to leverage those interests to be what you're describing right now is as resourceful as we possibly can in advancing the work. That's terrific. Also seeing a couple in the chat, one from Christine, just around general engagement, buy-in, getting people, involved in owning the work with us. And then Amanda noting too many projects and time challenges in this burned out context. So, prioritizing this over something else when there are a lot of pressures on people as it is. Were there any other hands up?
I didn't see any.
Okay, thank you. Thank you for sharing these. And of course, feel free to locate this in whatever context you're facing around that. These are not uncommon. These are common barriers to improvement that you see here, the ones that you also named. Time challenges, maintaining motivation, engaging people in buy-in. So just wanted to also normalize that whether it's burned out times or just regular times, these are challenges that improvers face, and these are adaptive human challenges. And what do I mean by that? Well, if we look at why a lot of improvement efforts fail, it's not because they have bad strategies. In fact, the evidence base is strong. The change ideas are sound. The bundles that people are taking forward are clear. They have measures that make sense. They're using some improvement methodologies and tools that are technically effective. And the piece that really gets in the way, most of the failure in improvement comes from the adaptive or psychological side of this. And so we're going to be taking that on, thinking a little bit more around that engagement, around that ownership, around that alignment of interests, to think about the way in which we engage people around why it matters to them, and bring them into relationship and commitment around the work in a way that sustains their motivation over time. And so this is the idea that, in improvement work, of course, there's the technical side, that expertise that's needed to tell us exactly what is called for in these interventions. There's a problem, we're trying to fix it, it's clear, and this is how it will be fixed. So if only we take these improvement ideas forward, the piece of that is most challenging is the idea that those that need to engage and own the solution and be the authors of that solution with us, they have to learn how to take that forward. There's change involved in what their behavior is or how they work together. And those stakeholders themselves have to experiment to make progress with the evidence that we know will help them be more effective. So we're going to draw from the wisdom of this beautiful woman. Does anyone happen to know who this is? You can just unmute yourself if you recognize this woman. She's from the UK. She's a Nobel Prize winning author. Her name is Doris Lessing, and she wrote a book called The Prisons We Choose to Live Inside. The Prisons We Choose to Live Inside. It's actually a short book, and it's a wonderful book if any of you are interested in some summer reading. And in it, she says, we know more about ourselves today than we did in the past. We know more about ourselves today than we did in the past, but very little of this knowledge has been put into effect. What is she saying? What do you think she means? We know more about ourselves today than we did in the past, but very little of this knowledge has been put into effect. Any thoughts? All right, I'll tell you. So she's saying that, we know what to do. We have the knowledge, but the ability to translate that knowledge into behavior change is where we're limited, right? There's a gap between what we know, the evidence, and what we do, our behavior. And as we continue to, we're really good at producing new knowledge and new evidence, especially in the sciences. And so we have produced a huge amount. And if only we could quickly absorb it to change our behaviors to keep up to it, we would close a lot of gaps. And this is often referred to as the no-do gap. And of course, your work as an improver is to close that gap. I like to call that gap the justice gap. And what I mean by that is there's something that's deeply unsettling for a quality improver about the difference between what we know and what we do, or you wouldn't be here. You wouldn't be advancing this work. This quality work matters. It matters to your mothers. It matters to their families. It matters to their babies. And so we know that there are different pieces of evidence to take in, and from us that comes from a place of love, a place of justice, a place of wanting to make things better. And I like to frequently cite Cornel West, who's a theologian and political scientist, who said, "Love is what justice looks like in public." I'm sorry, justice is what love looks like in public. Justice is what love looks like in public. And I think a lot of what moves us to do this work and motivates us comes from a place of love for those families, patients, carers. And so we're tapping that in ourselves. And the question is, in part, how to help connect those with whom we're working to those motivations, those values around closing that gap. Because we know that if we don't have a deep sense of the value of the work, of why it matters, if we're not connected to our own motivations, we're not going to get folks very far along that path. And so, in other words, even if we know what that path should look like, even if we have a rational set of directions for the rider on that path, for the people taking it forward, if the rational mind, directing the rider, and the environment within which we're working, we're trying to shape, but if we're not connected to people's hearts, then we have a challenge about getting them along the path, because that in Switch, a book by Chip and Dan Heath, it's they posit that the motivation, our motivation, will stop us every time. That 5-ton elephant's going to win. It's going to stop us from moving down that path, no matter how good a strategy we have. And so why is that? What is happening there? This is another theory from Everett Rogers. He wrote a book called Diffusion of Innovations, and he posited that the rate at which change spreads is based on people. You have innovators, early adopters. You're a part of the early adoption group, right? That is building off of an evidence base, or perhaps innovating to create a new evidence base around the changes you're taking forward in your own settings. And then we have some people that raise their hand and want to join us, who are also early adopters. And then there's this chasm, and this is the work of improvement. This is the work of being an improvement leader, which is how to cross that chasm to reach enough people to make this a part of standard practice, so we get to a tipping point, and others will join us. It actually, in more recent research, it's not as many as having 50%. It's actually having about 25%, where you can get enough momentum. So that's good news for us. 25% to get enough momentum to turn that into standard practice. And this is really a reflection, not so much of math, but of how people think and feel. Simply how they think and feel. That elephant, right? How they feel about the change, especially in the face of the system challenges that we talked about earlier. The various types of other priorities and time challenges that they face. So what gets in the way as we invite them to join us in that engagement? What gets in the way? And what you see here is something that helps inform us about what happens when we encounter change psychologically. And some of you have studied stages of grief, may recognize some parallels or similarities here. But this work demonstrates that we can start from a place of denial that change is even needed. Now move to a place of resistance, then to exploration, and then to commitment. Now, of course, we're complex humans. We can think and feel more than one thing at one time. We can also have different feelings about different parts of a change. Like in theory, I like this, but in practice, I feel this way about changing my behavior. So, not to say that it's this linear, straightforward. And there are yet still patterns and trends that can be helpful to us as improvers when we notice in ourselves or when we notice in the people with whom we're working how they're showing up about how they're taking it forward or not. And then there are strategies for us about how to support them in moving from a place of resistance to one of exploration and commitment to the change. And so I wanted to help us all internalize this graph of moving across these stages by touching on something that happened to all of us at the same time, which was the COVID-19 pandemic. And if I could, take you back, you probably would not like to go back, but to March 2020. And if you could think about in relation to COVID-19 and all the changes coming down the pike in your personal and your professional lives in that month, how did you feel then? Were you in a place of denial or shock? Were you having feelings of anger or frustration or uncertainty, feeling a sense of resistance toward what was being sort of called upon across the world from all of us? Were you in a place of deep exploration at that point or commitment to the changes needed? So if you could plot yourself on this graph in March 2020, where would you plot yourself? Predominantly, you may have felt more than one thing, but just more on a whole. Any thoughts? You can just type it in the chat, or you can unmute yourself. Thanks, Laura's saying uncertainty. Ashley's saying overwhelmed and frustrated. A lot of some were in commitment, some in uncertainty, fear of loss, frustration. Yeah, I remember at one point I had this weird internal conversation where I was like, this is going to last for 2 weeks, and then it's going to go back to normal, which now is absurd, but that's just bargaining, right? Like that's that idea of bargaining with yourself. Yeah, also, yes, and there could be two things, right? Like you could feel, I got to rise to this, but I'm also really afraid of what's happening here. Okay, so thank you. How would you plot yourself today with regard to the changes around COVID? Whether that's masking or PPE or the ways in which maybe you vaccinate yourself or your family, how you manage that in your care setting. If you had to predominantly plot yourself today around the changes to COVID, where are you now? Are you still in a place of fear of loss? Or do you see yourself somewhere else along this graph? Yeah, so Mitzi's saying understanding and acceptance. Amanda's adding in acceptance and a desire to evaluate for improvement purposes. Yeah, so that's the idea here, is that we change over time about how we feel about change. And so do others. So do others. And that's really good news for us as improvers. Because just because someone's resistant to that change right now, because there's something else staring them down in this burned out time, doesn't mean they're always going to feel that way. They're probably experiencing some kind of uncertainty or fear or frustration. Maybe it's because their workload is so great. Maybe it is because of things outside of the workforce that are happening in their own lives. And so the idea for us is not to take it personally. It's just not to take it, to recognize that we're all human and that we too sometimes have resistance to other people's change ideas and other people's improvement work. So the question for us then is, what do we do with it? How do we support people through that? And how do we recognize that that's something we should expect, right? So we're working with the model for improvement, or you may be using other tools and methods for improvement. But if you would sort of humor me around the model for improvement, if you're thinking about improvement work, what what part of the model for improvement is today's session about? How is the work that we're doing around people's motivation, if this is part of our improvement skills as leaders in this work, what one word that you see on this slide here are we focused on today? What one word? And whoever gets it first will get a prize from me. If you put it in the chat, what do you think we're most focused on in thinking about engaging people in this work in burned out times? Any thoughts? There's only so many words on this page. I see change, developing change, aim, improvement, act. It's none of these words. Keep going. Improvement, nope. What one word? It's not do. It's not plan. Motivation isn't on there, but good try. Good try, Bridget. No, this is amazing because, again, there are only so many words on this slide. Who's going to get it? Oh, Jennifer got it. Jennifer gets the prize. It's we. It's we. Because, and here's your prize, Jennifer. You ready? You're going to get jazz hands. My infamous jazz hands. Good job. The idea here is we don't have an aim, right? We don't have a how or a change idea. We don't have, a measure if we don't have a we to start with, right? The we is the first step, actually. The what and the how and the plan, do, study, act cycle, that all comes after we have people who care. So the first question is, who are our people? It's a precursor question to the model for improvement. Who are our people? And I think we heard earlier, that knowing who's aligned with us, knowing who our allies are, knowing who else is doing this work and who could care about it is really important to being resourceful and leading it. So who are those folks? And why does it matter to them? What are their values? What are their interests? How do we connect them to their motivations for growing, for having autonomy, for making improvements to their own workday, for focusing on meaning and purpose and patient care? So the two questions that almost for us are even more critical, not more, but also critical to ask are, who are our people and why does it matter? Okay. And so as we do that as improvement leaders, I want to invite you into some shifting mindsets, which the first is, even though it feels frustrating to encounter resistance, it's not the worst thing in the world. Because do you remember that curve around the first step isn't resistance, it's actually denial. So that it would be worse if people were denying that these changes were needed. Resistance suggests that they recognize that change intellectually might be called for, but there's something emotionally that is getting in the way of adopting that change. And again, those could be real barriers, real structural issues in our systems, and how we feel in the face of that entire context and more change on the pike. So the idea here is for us not to take it too personally, and to expect it, to expect resistance, to expect that people are going to feel these other things or be preoccupied by these other things. And then it just creates a dilemma for us to how to work with that and how to meet people where they are, rather than trying to prove our point or persuade or cajole or, try to convince someone else of why they should be doing this because of the rational. What we find in the brain science is that people will dig in more when it's sort of presented as an argument. In fact, we will defend our own positions or our own feelings, because those feelings will then actually, like I said before, gum up that prefrontal cortex, and we'll come up with all kinds of reasons why it's no good, why it doesn't work for us, because we're having feelings that trigger that rational response. So that's that elephant getting in the way of the rider. And so the idea instead is to work with it, is to tap into it, is to embrace it and accept it and explore it, so that it's not something that we're fighting against, and people don't feel us fighting against them, but instead we're recognizing that that's real. We have compassion for that. We have empathy for that. We have a sense of being curious about that and wanting to understand more about that and allow our curiosity to itself become an intervention that supports people on their own journey to becoming more ready and exploring their own thoughts and feelings about what would be possible or what they might explore moving from resistance to that stage of exploration. Another way we can do that is not just trying to convince people, but stop telling them also what to do. So we may be also in some position of authority, and we're trying to get people to do what we want them to do. And the idea here is, how do we get them to do what they want to do? How do we tap into, again, moving them through those feelings by helping them feel something different through the intervention? So I'm going to go back to that earlier comment about who are our people and thinking about our allies, for example. And I'm going to give an example of another piece of improvement work, which is a surgical safety checklist that was taken forward years ago in 2010 by a person in South Carolina named Dr. Michael Rose. And he was advancing this as a VP. He was an anesthesiologist, and he could not seem to get the surgical safety checklist adopted beyond about 30% in the ORs. And together they had tried so many things in terms of persuading and cajoling and marketing and putting signs up and reminding, and then ultimately mandating, from the most senior leaders down that this should be how we do business. And yet they couldn't get folks over that 30% adoption rate. They couldn't turn it into standardized practice. And so he was given a leash to try a different approach. And one of the people he had to respond to was his CEO. And some of you may also be working with senior leaders who want to know what is the return on investment and giving you the time and space to do this work in your own system. And what Dr. Rose had to confront was a conversation with his CEO who said, we need to see the difference you're making in leading this work, not just in terms of, we know it's going to improve quality, we know it's going to improve patient care and satisfaction, we know it's going to improve how people feel about the work that they're doing in the long run because the results will be better. The evidence is clear. We get that. But we haven't changed enough behaviors, and maybe it's time to move on to something else. And what the CEO wanted to know was, and what am I getting back for this investment, right? We're putting money to this, we're putting time and energy towards this. What are we getting back? And so what Mike was doing is, in this very kind of busy slide, was he was saying, well, I need buy-in from my CEO to have more time to do this work. I need commitment that it matters and that it's going to continue to be.
Hey, Kate, I'm sorry to interrupt you. I think you accidentally got muted.
Thank you. Is that for a while?
No, just for like 3 seconds.
Thank you. So the second question was, well, then who had the assets to help him with what he wanted? Of course, that was mapping his actors. So the question for you in the work you're leading is, who are all your allies? Who are potentially people who have different commitments that they can make to help you advance the work, whether that's a senior leader, whether that's a frontline team, whether that's someone who's a measurement guru, someone in HR, or someone in patient advocacy, or a family member. So who has the assets to create that change that you're leading? And then what is it that they want? And this is the key move here. What is it that they want? What do they care about? What matters to them, both not just on the basis of their interest, but also on the basis of their values, why they show up at work, why they care about their job, why they care about patient safety and quality. So what is it that they want? And in this case, what Michael was hearing was the CEO wanted to demonstrate that they were saving money, or that they were, able to somehow, enhance the bottom line at the hospital. And so Michael had to ask himself, well, this isn't what I wanted to do. I didn't really get into this work to measure the ROI, but I know that it's important to this stakeholder, and it matters to this stakeholder, and in this case, his values and his interests, to bring my own set of assets to do so. So what he began doing was measuring the labor hours that were saved per case and the throughput, so the ability to increase the case count based on the safety and the way in which, using the surgical safety checklist in this case allowed them a greater throughput of more cases because they were also saving time and saving labor hours per case. And so as a result, they saved money through the labor hours and they increased money through the throughput. They discovered that they had $7 million annual revenue, either savings or generation, that was going to the hospital. And so that's the idea for us is, how do we listen to the people who we're trying to engage in this work to understand what it is that they care about, what they want, how this work can help them in order to help get as resourceful as we possibly can through those regulated conversations in which we're relating and listening and showing curiosity about how they think and feel to come up together with some strategies for that. And then last is just that those who are already with us, those who are already, part of those early adopters, are people that we want to really stay committed on. That in fact, a source of our own motivation and our team's motivation, even if it's a small but mighty team, is one another. And to secure and harness and build momentum on those who stand with us already, who are deeply motivated to this work, is critical. And as we do that, we might want to think about an additional strategy in those relationships, which is connecting people to other people through their social connections and social influence across our organizations to lead that. And what do I mean by that? You might structure it in a really clear way of teams of people taking forward different parts of our bundle or of our change ideas, where we're sharing responsibility and different folks are taking on different roles. Dr. Rose did this in his case. He was working with those technicians and nurses. He was working with anesthesiologists and surgeons. He got senior leaders engaged, and they formed a core team. And many of you have been working with a core team, taking your work forward. And what they did, and I hope this might be also useful, is that, of course, we take for granted all the meetings we have with people all the time. And what they got very intentional about was, who do we know? When I map those actors, who are our people, right? That question number one, who are maybe 3 to 5 to 7 people I actually have some influence with? And so they divvied up one-to-one meetings across people with whom they had influence to recruit them to participate in this work. And then when those folks committed, the thing that they asked them to do was to have one-to-one meetings with 1 to 3 other people with whom they have influence. And they started creating, they had a board, a visual management board, where they had the faces of the people engaged and committed to the work. And they continued to, they went from 5 people to the core team to 15 to 50. And they actually went over time to over 700 staff through this relational strategy of getting with their people and talking about why it matters. And not telling why it matters, but eliciting, why does this matter to you? What are the things that you care about? What are the things that you're interested in? And connecting the dots between our change ideas and the people and what they think and feel, and then inviting them into a clear commitment to get engaged in the work, whether that's the change idea or whether that's actually part of that relational strategy in bringing more people along to take it forward. So that's something that we think about as power that we build through our relationships. And we see the evidence of this in health care improvement through work that was done at Warwick Business School in the UK around National Health Service quality improvement intervention that went on at 7 different trusts, which are hospital systems in the UK. And what they did is they gave an equal amount of resource around quality improvement, support, coaching, evidence-based, similar to a collaborative like yours, in these 7 trusts. And they discovered that 4 of the trusts did really well, and 3 of the trusts did poorly. And they looked at comparing and contrasting and controlling for what were the variables. And what it came down to was a trust that did an outstanding job with the quality improvement work were focused on and had strong networks of interconnected humans committed to one another through their relationships to take the quality improvement work forward. And those that didn't, you can see here, did not have those relationships. And so right now, I know it feels, in burned out times that taking the time to be with and see one another feels like a lift. And yet at the same time, it's the most important thing we can do to support each other's regulation, connection, right? The things we started with around feeling a response to burnout that is deeply connected and supported, and also results in real commitment to taking forward the work. So this comes in sort of the system of profound knowledge that we inherit from Edward Deming as part of the kind of base of quality improvements founding thinking around psychology. And the idea of supporting people with the psychology for change, because people want to create value and they are our fundamental source of value in quality improvement. And so we want to create not just systems, but cultures of motivation that sort of drive out that resistance that comes from a place of fear or uncertainty, and instead really invites people to be partners with us and treats them as, with respect in the work. And so you can always learn more in this white paper. I won't spend too much time on this, but just to give you a sense that there's a lot of theory around the psychology of change, that some of which I've introduced you to today, which is really fundamentally about activating people's agency or their intrinsic motivation to take the work forward and move them from that resistance to a place of exploration, and to plan, do, study, act, cycle their way through some tests of change for the stakeholders, experiencing this change to be the authors of its solution and to be the learners. And that means, connecting to their ability to take that forward, or their power to act with purpose, and their courage, the ability to choose to do it in the first place, those emotional conditions, the elephant, if you will. And of course, this can happen at multiple levels within your system. Now, we can't always control some of the structures and processes, but we can look at parts that we can control within our own locus of control. And this is in the framework. I'm not going to get into all of it here, but the area that we might want to focus on, given the topic at hand, is unleashing people's intrinsic motivation, tapping into why it matters to them to act. And there are plenty of skills we can use to do this. One is storytelling, whether that's our own story, whether that's the story of our mothers, our babies, our families, whether that's the story of how that affects the care team or the organization as a whole, why it matters now. We also have ways in which we can design the work itself to be motivational, to allow people a sense of agency and control, the ability to learn and grow, the ability to feel a sense of control in the work, that they have real ownership over it. And then finally, also to bring in things like play and celebration and appreciation and gratitude, things that create culture around the work that's focused on appreciation. And so those types of things can support us and center us on why the work matters, and also then help us internalize as part of taking it forward to be connected to those intrinsic motivators, the way in which it's designed. Now, there are other ways we can do this in supporting people to do that for their own workforce well-being. There's another framework from IHI around joy in work that you can connect people to as a strategy to make meaning around why these interventions can help us address our own well-being in caring with and for our patients around the things that matter to us. And also that are things that we can just get done, that some of these change ideas, we can look at where do we currently have some low-hanging fruit that we can address, or where can we start anyway with regard to those small wins. And of course, many of you have started with those long ago. But that's thinking a little bit about where do we start with regard to shrinking some of that change, and where we have a workload around the improvement work that is not super high, but it is sort of it's at its most reduced. It takes change ideas to get them adopted, that they have high value and are easy, right? So we see that it'll make a difference quickly and it's easy for us to tackle. Those would be places to start the work, or to think about where do we have opportunities to shrink the change to make it a reduced workload or high value. So as we're looking at what we're doing now, we could ask ourselves some questions around that. And that's the idea of a highly adoptable change checklist. There are things in our change ideas that may be more highly adoptable than others, and there may be things that are going to take more time and effort, and we might want to think about how to break them into pieces or chunks that move us towards things that are, in fact, highly adoptable. So this is the idea of thinking about the workload as a consistent balancing measure against the improvement work itself. And thinking also about how to simplify what it is we're doing or remove any wasted work as part of it, so that it takes that workload down for folks, and of course have high value, so that there's a high degree of belief. I'm not going to get so much into this because I really want to move us along, but I will just say that we can design for a to address that workload, to address the complexity and simplify, to think about the efficacy, and the resource availability or alignment with things that we already care about. So how does this already value? Like I showed with the Dr. Rose example with the CEO, how can we align this to what other people care about? Or how do we engage people directly who are going to be involved in the change in adapting it, making it better, making it more appropriate for their particular context or the regulations within which they may be working. So these are just a few things to think about when we evaluate that, because we do have a locus of control around what it is we can do, even though we're working in these burned out times at a system level around some things that affect us and our ability to do this work beyond our control. So given all of that, and that was a lot, what stands out to you? What is something that feels like, ooh, maybe I could try this, or maybe that mindset would serve me? What's one thing you could test in the work that you're doing to address engagement, or to address alignment with other stakeholders? How do you see the relevance of this to something you could take forward, or you could ask one another for some coaching and support around how to imagine that? Any thoughts? Beverly, if we go back to your example from the very beginning around alignment of stakeholders, how is that showing up in your system right now? Who are some of the other stakeholders you can be engaging?
Well, we have opportunities. Of course, we are a pretty big system, and we have several women's health services through our system, a total of 4. So I think what is impactful for us is just making sure that our providers are aligning with the protocols and the things that are common to all. And so I would say sometimes it's our making sure that our obstetricians and our anesthesiologists are at the table at the same time when we're trying to change nursing workflow and things that we do. I hope I answered your question.
Yeah, so I'm hearing, I think maybe 2 parts of that. So one is having the 4 different centers engaged and involved and aligned. And let's start with them. How have you engaged them already?
Well, we've definitely have committed to meeting together monthly now, And we still meet as individual hospitals, but then we come together and speak as one voice for the system. And so more to come on that. We've just started the storming part of it.
Mm-hmm.
Yeah. So
Understood. And so congratulations, by the way, that you have them together and that there is a sense that we have shared interests and shared purpose around this work, and that everybody has a stake in contributing to making that happen. And then how, as they're engaging with their own workforce, and taking the change ideas forward, where are you seeing the greatest uptick, or where are you seeing folks most committed to that work? It may be in a specific place or team, or it may be based on a specific part of the change package.
um, I don't know how to answer that. I think we're doing so much, and so um, we have quite a few things that we can, I guess, celebrate that we've
Great.
done. And so yeah, I think that closing the communication is what we're working on, making sure that um, things that are shared, we just make sure that we make sure everyone's aware of it. Then we kind of pick a target date to start things and making sure we're all ready at the same time. But that's kind of hard for me to answer as we're still storming.
Yeah,
So,
that's fair. But I appreciate also when you're storming, your insight that one of the things we could do is actually celebrate, is recognize that we bit off a lot, and that we've actually already accomplished some things. And that can also help us in the storming phase move from storming to the next phase, which is to say, like, hey, thank you for this. Hey, I appreciate that. Hey, I want to recognize that this got done. Hey, these are the strengths. How can we learn from the things we've done well to do more of them? And that can be a really important conversation to have with those stakeholders and with their stakeholders. So not just when you meet as a team monthly, but then when they're going back within their own teams, really celebrating and raising up what is working and how that's going. And I will also note a big thank you to where it didn't work. So in other words, here's what we learned. We learned that this is not working as easily. And that is a fantastic learning for us. Thank you for that. In other words, making that psychologically safe by not calling it so much a failure as we are a plan, do, study, act cycle that allows us a new insight that we're going to have to try something differently in taking it forward. Now we know not to do X, Y, or Z. So that's really useful. Great. I'm also seeing Laura chimed in the idea of starting small with those with whom you have influence feels doable. And I think too, connecting Laura, that insight into, Beverly's example is thinking, well, who has the relationships with whom? What is that distributed leadership structure, for example, in your case, Beverly, across those 4 different care settings? And how one team comes together, but they have teams within their own setting. And then how are those teams structured? And how are those teams engaged? And what are those relationships and influences we each have? And then internally, what are our relational strategies for engaging those folks? Are we doing walkarounds? Are we doing huddles? Are we having a town hall around this work, or a grand round, or whatever it is, right? So thinking about how we're engaging people. You remember in Mike Rose's example around those one-to-one meetings, with whom do we actually have influence as we build out that network strategy? Conversation by conversation, leader to leader, nurse to nurse, person to person, around people we trust and people we admire and people we believe around what matters, and to explore in a conversation that is about what matters to us. To connect people to their motivations around why to do the work, but inviting them to articulate that for themselves. So just a few change ideas for you all as you continue to take this forward. I think I'll just end by sharing in the slides. We have a playlist for you around the psychology of change if you want to add your change anthem, so you want to get your teams pumped up. And I just thank you very much with a final jazz hands here around the work that you lead and do, and for having me join you today.